entrando. Vamos a dar un minutito para que la gente vaya entrando. Hola, Iradis.
Hi, Alan.
Buenos días. How you doing?
Fine.
Sí, se supone que acá Alan está preguntando si tenemos familiares, pacientes, profesionales, estudiantes. Entiendo que hay un poco de todo. I think we're going to have a little bit of everything, Alan. Okay, so, bien, buenas tardes. Voy a ir comenzando presentando a Alan. Primero les dejo saber que vamos a darle a Alan va a estar como 50, 60 minutos presentando. Vayan poniendo sus preguntas, las pueden ir haciendo en el chat. Y luego de eso, pues él nos va a dedicar el tiempo necesario para atenderlas. ¿Está bien? Así que si usted puede poner también las preguntas en contexto, ¿verdad? Si usted es un estudiante que está en adiestramiento, si usted es un profesional, si usted es un familiar, si usted es una persona que vive con el diagnóstico, pues es importante que lo ponga en contexto para que entonces él pueda hacer lo mejor posible en atender sus preguntas. ¿Está bien? Eh, y ahora, Noelia, ¿me confirmas que estamos listos para arrancar? Bueno, pues le tengo, ¿verdad? La alegría de compartir con ustedes esta tarde. Mi nombre es Domingo Márquez, soy catedrático en la Universidad Carlos Albizu. Y lo importante hoy es que está con nosotros en este mes de despertar conciencia sobre el TPL, que hemos estado haciendo algunas actividades, ¿verdad? Y vamos a comenzar también. Mañana tenemos nuestro simposio. Logramos convencer a Alan que estuviera con nosotros hoy para compartir con nosotros esta conferencia donde él nos va a estar hablando de las familias y del manejo también de adolescentes y adultos con el diagnóstico de TPL. Su conferencia va a ser en inglés. Ahora yo voy a estar acá, si creo que hay cosas que no entiendan o necesitan ayuda. eh, estamos para eso también a la hora de aclarar con las preguntas. La conferencia se va a estar grabando y luego se va a subir también a las redes. Esto es parte de los esfuerzos que estamos haciendo en la Universidad del BISU para despertar conciencia del diagnóstico. El doctor Alan Frusetti, persona acá. Eh, el doctor Alan Frusetti es un investigador, es profesor y es supervisor de DBT, reconocido internacionalmente, ha publicado varios libros, tiene cientos de artículos e investigaciones publicadas, trabaja, ¿verdad? Lleva un tiempo trabajando en el Hospital McLean de Harvard. También ahora está ayudando a que se establezca en el sistema de salud de Irlanda, el DBT, a través de todo el país. Así que se ha ido para allá un año para establecer eso. También es profesor emérito de la Universidad de Reno, Nevada. Alan es una de las grandes, ¿verdad? Personas que ha aportado grandemente al DBT con su sensibilidad para las necesidades de tanto de los pacientes como de los familiares. Alan, junto a nuestra querida Perry Hoffman, crearon el programa de vínculos familiares, ¿verdad? Un programa que crearon primero toda una organización para atender a la familia y crearon un programa completamente gratuito para familiares, ¿verdad? Un programa que hemos traído a Puerto Rico y que hemos hecho la traducción de los materiales también. Y bueno, Alan también es tremenda persona, tremendo papá, tremendo, y ahora abuelo, eso es lo nuevo, ahora es abuelo Alan. Y ahí lo tienen alimentándome en una de las veces que nos hemos reunido para trabajar. Así que espero que les saquen el provecho, como siempre, porque es uno de los más grandes conferenciantes que tiene el DBT y es un conocedor del tema. Así que sin más interrupciones, los voy a dejar con Alan para que pueda comenzar. So, Alan, you may start now.
Muchas gracias. Okay, so thanks so much for inviting me to come and talk with you all this afternoon. It's just my pleasure to be with you. I'm just sorry I'm not there in person because it's so lovely to be in Puerto Rico, but not today, I'm afraid. So I'm going to put some slides up, and we're not so many people. How do you want to do questions? Should people send them to you, or I won't really see the chat because
we'll put them up in the chat, and we'll, if I think we should attend to it answer it during the we'll do it. If not, we can wait at the end.
Yeah, totally okay to stop in
Yeah.
the middle of questions. Fine, totally fine. Okay, so I want to talk a little bit about this idea that emotion, and in particular emotion dysregulation, occur in a family and a social context. These days, most of the messages we receive from the mental health world and from the cover of newspapers and magazines and internet flashes say that emotion is inside the person, it's in our brain. If we have dysregulated emotion, that's in our brain. And in fact, that's an interesting model that, of course, there's emotion going on in our brain. Brain is partly where emotion lives, but emotion also lives in other places in our bodies, in our fingers and toes and heart and muscles and respiratory system. And it also lives in a social context. And the social context and family context in particular are very relevant to what we feel, what we experience, and how we learn to manage those emotions, how other people respond to us, how we respond to them, and the transactions, meaning what I do affects you and what you do affects me. That's a transaction. Those things are extremely relevant to our experience. So that's what I want to talk about today, and explore a few studies that we've done that illustrate both at a very basic level of psychology and emotion, what we mean by the social context or family context of emotion, and also some treatment studies to say, oh my goodness, look at this. When we actually include parents of teens or younger kids and partners of adults, or parents of even young adults, if they're still living with their parents, that makes a big difference in terms of treatment outcome. Now, in some cultural contexts, people say, well, of course, I'm hoping that a lot of you are saying, sure, that makes sense. I hope so. If you're saying that's ridiculous, it's all in the brain, I hope to change your mind in the next hour. And even if this is something that makes good sense to you intuitively, I'm hoping to give you some very detailed ideas about what those mechanisms are, how it is that what I do affects you at an emotional level, and how what you do affects me at an emotional level. Therefore, what I do also affects you, therefore affects me. What I do with respect to you has an impact back on me. All right, so let's take a look at this. We've known for now, 55 years that family distress, family dissatisfaction, couple distress have a big impact on individual well-being, individual distress, and what sometimes is called psychopathology, things like depression, anxiety, borderline personality disorder. Some studies suggest that if you're, for example, in an unhappy marriage or marital-like relationship, that you're 10 to 25 times more likely to be clinically depressed than if you're in a satisfying marriage or marital-like situation. That's not a random event. That's not a strange quirk. It has to do with this double-sided arrow. And in fact, in psychology and in psychiatry and medicine and in sociology, there have been lots of arguments about the direction of this arrow, with most people arguing, oh, an individual where they have something in their brain that's broken, that causes distress in their relationship. It's a very linear model. Turns out it doesn't fit the data very well at all, but it's a very linear model. And it lends itself to most of the individual interventions that we've come accustomed to see in the last 50 years. However, the other direction of this arrow is just as valuable, that in fact, being in a distressed relationship is upsetting. It doesn't feel good. And if we stay in a distressing relationship for a long time, it can wear us down and create all kinds of ongoing individual distress and medical problems and all kinds of things. So this is not all that surprising, even though it's not currently mainstream thinking in some places, in certainly many places. The question still remains, well, okay, these things influence each other. The arrow goes both ways. Well, what's the mechanism? How does that happen? What's the process that connects these two dots? Okay, and of course, I'm a researcher and a therapist and a supervisor and a teacher, and my interest in this has to do with emotion and emotion dysregulation. So one answer to this question is that emotion dysregulation may be the link, the way we understand how it is that I affect you and you affect me in a close relationship. So let's take a look at what we mean by this. First of all, I want to define emotion dysregulation. Now, emotion dysregulation is not the same as simply being upset. Okay, I want to be really clear about that. So let's just think about this for a second. Okay, I'll put the slide back up in a minute. But if you think about, anybody here ever said something? Most of you don't have your picture up, but you're going to have to answer this on your own. Anybody ever said something mean to someone that you love? Anybody ever done that? Okay. I don't know. I hope everybody's hand is up. If not, you're not being honest. So when we say something mean to someone we love, that's an example of dysregulated emotion. Right? It must be. Why? How do we know? Because if you love somebody, you want to have a good relationship with them, you care about them, you wake up in the morning, you don't think, I think I'm going to have a great day. I think I'm going to say something really mean and nasty to this person that I love. What a great day that'll be. Nobody does that. Nobody does that, right? When our emotion is down, our negative emotion is down, we're having an okay day, nobody plots how to be mean to somebody else that they love. Maybe somebody they don't love, but certainly not someone they love. So when we say something mean to someone we love, that means it's impulsive and reactive, and it's got emotion at its core. So when we talk about emotion dysregulation, it's not unlike, say, pain, okay, physical pain. You can have physical pain and still go about your day. You might not have the greatest day, but you can still go to work or go to school or take care of kids or go to the grocery store, or ride the bus, whatever it might be. Get a shower, make dinner, But at some point, I hope this has never happened to you, but it probably has, or certainly somebody you know closely, the pain gets so big that the only focus is getting rid of the pain. Go to work? No way. Go to school? Ride the bus? No. Get in the shower? I'm not worried about a shower. Make dinner? You're out of your mind. Okay? No. What I've got to do is get rid of this pain. And now, of course, people have different mechanisms for getting rid of pain, depending on whether they're chronic, they understand where the pain's coming from, and so forth. Sometimes it involves things like medication. Sometimes it involves more radical medical interventions. Sometimes it involves stretching. Sometimes it, involves physical therapy. There are all kinds of things we do, breathing, meditating, all kinds. Now, if we take that to emotional pain instead of physical pain, emotions are just the same. We can have a lousy day, you know, maybe Domingo, cancels, we're supposed to have lunch and he cancels lunch with me. I'm disappointed. Of course I'm disappointed, but I can be disappointed and still go back to work and have a perfectly productive day and visit with a different colleague. I can have a nice lunch, to go buy something and bring it back and eat it by myself. I can enjoy that. That's okay. I would have preferred to have lunch with Domingo, but okay, I can be sad about that, disappointed, and still have a good day. However, if emotion gets painful enough, it's the same thing as physical pain. We hit a tipping point, and then the only thing we're focused on is getting rid of the pain. That tipping point is the point we go from possibly intense and painful emotions, but ordinary emotions, to dysregulated emotion. And sometimes that happens quickly, and that's when we say things and do things that are impulsive, sometimes mean. Sometimes that's also when we do things that are extremely destructive, like make a suicide attempt, or relapse into drug use, or self-harm, or fill in the blank, binging and purging, restricting eating, okay? Going back to bed instead of going to work or school or whatever else you might have had. So all of those things are
Alan, I'm
dysregulated.
sorry.
Yeah, yeah.
We're not seeing your slides. I
No,
don't
no,
know.
I'm going to go back to the
By,
slide.
by
Two
design,
slides.
okay.
Yeah,
Sorry.
I wanted to sort of interact a little bit around this. So, and make sure that everybody knows when we're talking about emotion dysregulation, we're talking about us. Okay, and then we're also talking about people. The more frequent and chronic the emotion dysregulation becomes, the bigger problem it is in our life, and the more likely we are to classify it as a problem or as a disorder. And that's the key part that I want to emphasize. Okay. Okay, now the last point here is very important. Because this behavior comes out of internal experience, other people often, A, don't understand where it comes from because it's emotion. And even if they have an idea where it might come from, the behavior that comes with dysregulated emotion is usually disruptive. We attack people verbally, we withdraw from them, we don't follow through on things we promised to do. We get angry when people ask us why we didn't follow through. And then they invalidate us back. They say, well, it's not that big a deal. Oh my gosh, you should have done it anyway. They get judgmental, they get invalidating. And as you'll see later, being invalidated is no picnic. It's not nice. So emotion dysregulation, one of the interesting things about emotion dysregulation is that it's transdiagnostic. Transdiagnostic means it goes across different diagnoses, right? Dysregulated emotion shows up in substance use problems. It shows up in eating disorders. It shows up in PTSD, shows up in anxiety, other anxiety disorders, depression, and it certainly shows up in borderline personality disorder. In fact, we can think about borderline personality disorder as a prototype for emotion dysregulation. That's the place where we see emotion dysregulation as the defining characteristic of the set of problems that we call borderline personality disorder. So,
Alan,
yeah,
we have a question that might be
sure.
useful to look at now. It goes, so a way to differentiate being upset from emotional dysregulation, I'm sorry, is an inability to engage in goal or values-oriented behavior.
Correct. Absolutely. If I can still act in ways that are consistent with my goals and values, I still have my wits about me. I have emotional pain, but I'm not dysregulated. I'm not going to say something mean and terrible to Domingo because I know I like Domingo. I care about Domingo. I want to have a good relationship with him. I want him to have a good life. I could have a lot of pain. If I'm not dysregulated, I'm more likely to say, I feel terrible. Can we talk tomorrow? Instead of like, why are you bothering me? You're an idiot. You're a jerk. Why don't you leave me alone? That's very different, obviously.
Because you have to regulate yourself to be effective.
That's right. If I'm regulated, I can balance the short-term goal of I want to feel better with my long-term goals. I want to not do damage to myself. I don't want to do damage to my relationships. I don't want to do damage to my goals. Not only do I remember that, but I can do it. I can manage my overt behavior. Yeah, exactly. Nicely put. Okay, so we know that kids, children and adolescents can get dysregulated. We know adults can get dysregulated, but also, not surprisingly, parents and partners can get dysregulated. And we can dysregulate each other. That's called a nasty argument. An ordinary argument may not include, we might call that a disagreement, friction, crabbiness. But everybody knows, okay, and if you're, I don't know, 11 or older, you know this, right? There's a point in an argument when the gloves come off, metaphorically, and if we regret later something that we did, that was a dysregulated moment. So each part of a transaction, what each person does, can contribute to the other person's dysregulation. And that's what I want to try to explain a little bit. All right, so here's the idea. Emotion dysregulation, I'm going to put in this, comes first. Of course, that's only a piece of the argument here, right? Of course, it's a cycle, but I'm going to start with it. Now, dysregulated emotion results in cognitive, behavioral, and verbal dysregulation. Okay, now notice this thing at the bottom, Yerkes and Dodson, 1908. That's not a typo. We have understood this as psychological science since 1908, right? They were clever. They looked at, like, gee, when people get physiologically, emotionally, more and more pain and more, like, what happens to their thinking? What happens to their problem solving? What happens to their performance? And in fact, there's what they called an optimal level of arousal, emotional arousal. And beyond that, we crash. And if the task is complicated, the optimal level of arousal is lower. If the task is routine, like, say, tying my shoes, I could be dysregulated and still tie my shoes. I've done it, I'm not going to count the number of times my age, but it's a very large number of times, okay? So I can tie my shoes probably under almost any emotional circumstance, but I can't have a nice conversation and ask my esposa maravillosa, how's her day? I can't do that if my emotion is way up here. I'm not interested in how her day is. I want to tell her that she's being a jerk, or this other person's being a jerk, and she better listen to me because my distress is what's important. I don't have the brain space for that. Okay. So we've known this for a long time, and it's called the primacy, if you will, of emotion. Emotion, sorry for this word, trumps cognition. Okay. Sorry about that. It just means, like, in cards. Okay, think of it that way. It beats out cognition. We can't think straight when our emotion is high. Now, cognitive dysregulation will dysregulate our emotion too, but it doesn't, it takes longer and it's a different process. So, but of course, what happens is when we have dysregulated emotion and then we can't think straight, we can't problem solve, we misperceive, we misremember, and then we do things that other people don't understand and maybe hurt them, hurt their feelings, are strange, and we perhaps say nasty things. Other people react to these kinds of dysregulation and they contribute to further dysregulation. And this is how this cycle gets going. So if we want to understand emotion dysregulation, we have to think, what could it look like? Because it can look very different. Sometimes the most common thing we think about with a person who's dysregulated is that they're really upset. They're big. They're saying nasty things. They're contorting their face. Their face might be full of blood, and that's one way, right? That's our lovely woman in the upper left here, this teen, giving the parent the finger, okay, or the guy next to her. But it can also look like, the people on the lower left and the lower right. They could be withdrawn and sullen and overwhelmed and just disengaged. It can be very hard to understand. So it's not the form of the behavior that tells us that somebody's dysregulated. Okay, there are other pieces that we have to look at. Now, I'm going to call this a transactional model, and I want to make a distinction between what is most commonly called an interactional model versus a transactional model. For those of you who don't care about the finer details of theory, just turn off your brain for the next 60 seconds and then come right back. Okay. Don't go too far. Okay. But here's the idea. An interactional model is the dominant model in mental health, has been since the 70s. An interactional model says that there's a factor A, like a predisposition, like a person's biology, their genetics, and then B, some stressor happens. And when those two things happen, you end up with a disorder, you end up with a problem. Okay, now, a medical version of that is an allergy, right? If you have a certain genetic disposition and your lungs are formed in a certain way, and then that's A, and then B, there's pollen around, then you sneeze, that's C. Okay, notice if you don't have that genetic disposition, that biological factor, and you don't sneeze, even in the presence of pollen. And if there's pollen around, but you don't have that genetic, just you don't sneeze, right? You need both things, then you sneeze. Now that's been around. That's what actually most treatments are based on. And it turns out it's a really lousy model. It doesn't fit what people actually do very well at all. Okay, now why not? Because A and B are independent. They don't have an impact on each other. A is just static. It just sits there in your life waiting for B to happen, and then B happens. This is why we have all these big event models. And in movies, you see therapists have big insights into something, and somebody says, "Oh, I see. I feel this way because that happened." And oh, all of a sudden, everything's fine. The clouds part, the birds chirp, and everybody goes home happy. Now, either I'm a really lousy therapist, because that's possible, or that's not actually what happens in therapy, because that's not what happens in therapy that I do. It's different. It takes longer. It's not just one event. It's not an insight. It's different. It's actually a transaction. Okay. Now and this does fit the data better. Okay. The idea in a transaction is that the factors influence each other. Okay. So if Domingo is okay, you got to use your imagination now because he's getting a little long in the tooth. I got to tell you, okay. He's my teenager though for the next 2 minutes. Okay, so Domingo's my teenager. Yeah, sorry, you and me both. So he's my teenager, right? And do the thumb thing on your phone. You're on the phone with somebody, right? Texting away. Okay. And Domingo has been struggling in school. He's been kind of lonely, and he's on his phone now. Okay. But he has not taken out the trash, and he hasn't set the table. He hasn't done his homework. Okay. But he's talking to a peer, a friend. He actually is kind of smiling and engaged and obviously having a pretty good time. Okay. And I come home from work, or I've been in the kitchen making dinner, and he's on his phone, and the garbage hasn't been taken out, and he hasn't set the table. And I see his homework bag hasn't even been opened. I say, Domingo, what are you doing? Get off your damn phone. You've got work to do. Okay. How's that, Domingo? How's that?
Well,
I love you too, Dad.
yeah, I'm busy. Can't you see?
Yeah, I do. I'm thinking I'm more likely to get one of these personally, but maybe you're kinder. Okay, so
What do you want from me?
yeah, but see, the idea is that what I do affects you, and what you do affects me. Okay, now as the parent, no blaming. By the way, don't be thinking like I'm a bad parent here for a second, because in fact, Domingo's been like suffering for months, maybe a year, maybe longer, and I'm really scared that he's gonna get kicked out of school, or he's gonna fail, and he's gonna have to start that year over again, and that would be terrible for him. So there's a lot of fear because I love Domingo. I don't want that to happen. But what happens is my emotion gets dysregulated. So instead of, "Hey, sweetie," try this one instead. "Hey, sweetie, who are you texting with?"
Just a friend from school.
"Oh, nice. How about one more minute, and then we got table to set, trash to take out, and of course you'll have some homework to do." I know that this is not
Why?
sweetie. You don't ask questions you already know the answer to. Come on. And by the way, what kind of ice cream do you want tonight? I'm going to go to the store now and pick up some. What kind of ice cream do you want?
I know why you're doing that.
Yeah, I'm being kind and offering you ice cream.
Yeah, because it works.
Yeah. So what kind would you like?
Chocolate.
All right, I'll come back and give you a nudge in a minute, okay? Off the phone. You can talk to this person later. Okay.
Yes,
All right. How's that? Is that different?
it is.
Right? I'm still aware. Now notice, what did I do? It's different. I remembered I have skills in the second version. I remembered that I'm so scared that Domingo's lonely and isolated, and I see he's on his phone and he's smiling and he's talking to somebody. I'm happy. I'm joyous. And I want him to set the table and do his homework. They're both true. But I can engage with my lovely son in a lovely way that invites him to notice that I love him and care about him. And I'm happy that he's talking to his friend. I'm not going to use anger as a force. I'm simply going to observe a limit and push him along. Okay. Now, I'm not saying that's going to work exactly that way every time, but that's the difference, right? Now, what I do affects him and what he does affects me. Notice that what he did, right, his suicide attempt 6 months ago has left me with fear. I've got a lot of fear conditioning. So what he's done affects me. I bring that fear gets queued up for me when I see, oh, his homework isn't done. I see a thing, I don't know, maybe, on his, from school that, he's almost flunking a course, I worry, but I also then remember, oh, but he's got 5 other classes he's doing okay in. All right, this is not a total disaster. It's like I don't know. Let's figure out what's going on in that class. Okay, so in our model, we're interested in the one person's vulnerability to getting dysregulated and their frequency of their dysregulation, which puts pressure on the other people in their life who don't understand. Right, dysregulated emotion is very hard to understand from the outside. Person's not giving us good information. We tend to invalidate. And we know that being invalidated is not nice. It doesn't feel good, and it further dysregulates us, which escalates their responses to the other person. And this goes round and around. If it doesn't go too far, we might only call it an argument. If it keeps going, we can call it a disaster. All right, so in a healthy transaction, that second thing that we just did, right? What's the event? Well, the event for me was I noticed Domingo hadn't done his homework and hadn't set the table. That was the event. I noticed it. But let's imagine that I'm okay. I'm not stressed out. I'm not too stressed out. I don't have massive vulnerabilities. What's my primary emotion? Well, I've got 2. I've got love and I got 3, love and happiness, because he's talking to a friend. He's not lonely. He's not isolated. I've come home many times and he's just lying in his bed doing nothing and sad, but he's not doing that today. So I'm happy and I love him. And I want him to, I don't like the fact that he hasn't done his homework. I want him to do his homework. They're all there. And so I can express myself accurately. And actually, he can acknowledge it. Yeah, okay. And that actually helps me. Okay. Similarly, if we did, and then of course, I'm using regulated behaviors and more skillful responses. It's easier for him to understand what I'm saying. He said, why? I just said, I'm not going to answer that. Come on, So, or we can look at it the other way. The event for Domingo is I'm saying, hey, sweetie, I know you're having a nice, conversation with your friend. I want you to get off in a minute and get to work on your homework. That's the event. What's his primary emotion? Disappointment. He's enjoying his conversation. He doesn't want to get off the phone, but his vulnerabilities maybe are kind of low because he's doing all right in other ways. So he expresses himself accurately. And like he looks at me, it's like, what's going on? Do I have to do this? Very totally easy to understand. It's accurate expression. He's disappointed. He's not dysregulated. He's using regulated and skillful behaviors. I can easily understand this is a hard transition, and I can validate him. I know that this is really fun for you. It's great. You can do this later, blah, blah, blah. I can be validating of his experience. And then I can also present new cues, like what kind of ice cream do you want? It's a new cue, right? It's a new thing to remind him, oh, right, there's more than just this disappointing moment. All right, but what happens is something very different when we get dysregulated emotion. Dysregulated emotion, right, is dysregulation creates invalidation, which creates more dysregulation. It starts out the same. Something happens. This is number 1. I'm going to number these. These are the sources of negative emotion, okay? Notice that number one is the same in a dysregulated transaction as it is in a regulated or healthy transaction. Something happens and we have a negative emotion, disappointment, sadness. Often those are the ones. It could be worry, fear, right? All kinds of things could be the primary emotion. The primary emotions, by the way, are adaptive and universal. Doesn't matter how old you are, what culture you're from. Primary emotions are the reasons we have emotions from an evolutionary point of view. They give us information, they direct our activity. And so that event results in a primary emotion. And if that's all that happened, none of us would ever get dysregulated. But number one is not the only thing that happens. Number two is sometimes we're vulnerable. And that vulnerability could be temperamental, meaning that we just have big reactions. We're very sensitive. It takes a long time to calm down. Those aren't ordinary things. They're on a normal distribution. Some of us are just sensitive people. Anybody here sensitive? If you're a therapist, you have to raise your hand. Okay. If you're a mental health professional, you have to raise your hand. Because why in the world would you be a mental health professional if you weren't emotionally sensitive? Somebody tells you their sad story and you say, so what's the big deal? Like, don't worry about it. You don't, you're not really considered a particularly helpful mental health professional if you do that. So mental health professionals are sensitive. Artists are sensitive, right? Musicians, writers mostly. Okay. So being sensitive isn't a bad thing. It's got its upside. It's also got its downside. Like having sensitive hearing means you hear things that other people don't hear. They're really there, but other people don't hear them. That means, what does it mean? Oh, it also means if you have sensitive hearing that when other people don't hear it, they don't know what you're reacting to and they're likely to invalidate you. And when loud noises happen, they hurt more because you have sensitive hearing. And then people invalidate you. Well, wasn't that big a deal? Geesh, what are you making such a big deal out of it? It wasn't that loud, but it was for you. So having certain kinds of temperaments and being around people with a very different temperament creates invalidating situations. Notice how we're already trickling into the social and emotional context. Okay, current biology, don't have enough sleep, don't have a good diet, you don't get any exercise, okay? Oof. You take drugs in a not useful way, all those things can create all kinds of problems. On a Monday morning, if you're hungover, didn't get to sleep till 2, woke up late, compensated by not having breakfast and having too much coffee, and there actually is such a thing as too much coffee. It just depends on the person, okay? And this event happens, our response is just going to be very different than if you had a good night's sleep and had a nice breakfast and got some exercise and got a hug from somebody who loves you. And then that same event happens. We call that resilience, right? Not vulnerability. There's also conditioning, like fear conditioning, right? If something bad has happened in that situation, we can respond with fear in a similar situation, even though the new situation isn't dangerous. And just based on how our day has gone, we just might have a lot of residual emotion. Those things in the presence of the event can make the emotion box bigger and help us go from having a simple primary emotion to secondary emotions. Okay, now notice that even things that we call individual vulnerabilities, like how sensitive we are, how reactive we are still transactional. What do I mean by that? Well, if you have sensitive hearing and you're out to lunch with somebody else with sensitive hearing, and you pick up something in the conversation at the table behind you, so does your other person at your table, and then there's no invalidation. But if you hear something and they don't, and you say, "Did you hear that?" And they get a little annoyed, like, "Oh, what are you listening in on the conversation?" And "Oh, I don't think that's true." You get invalidated. So actually, this mismatching thing is pretty important. So somebody who's got a temperament that's very different from the people around them is more likely to get invalidated. It doesn't mean that their temperament is wrong or broken or pathological. It just means it's different from the people around them. If that person can find their people, or even one person in their family that can understand their temperament, the quality of their life is going to be significantly improved. All right. So, and then of course, the third source of emotion is judgments. Judgments are when we say things are right or wrong, good or bad, and so forth. They spin us. They transform the emotion. They make it much bigger. If I say, oh, that person's a jerk, my emotion's going up. It's transforming from maybe disappointment. Maybe the person was late. I'm sad because I wanted to visit with them. I was worried because I didn't know where they were, if they were okay. And then they're there. Now I'm angry because they were late. It's like, okay, that's because I got judgmental. They shouldn't have been late. They should have told me. And that creates more negative emotion. Notice that this arrow goes both ways. That's because of that 1908 stuff a couple slides ago. When our emotion gets big enough, our ability to think and problem solve and remember our goals and stay descriptive goes right down the toilet, and we become judgmental. And when we're judgmental, it creates more negative emotion. So this arrow goes both ways. And of course, if this box of heightened emotion gets big enough, we start to be dysregulated. And then we do dysregulated behaviors, okay, which everybody knows the waggy finger. And then we express ourselves inaccurately, right? That's why I was teasing D'Amico. It's like, rah, 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 I love you too. That's not what people say when somebody's attacking them. But what they might mean is, I missed you. I really was looking forward to spending time with you, and you were late, and I was worried, and you didn't tell me where you were. I just missed you, and now it's so late. It's like, oh, sweetie, I'm so sorry. This is what happened, and I love you too. Much easier to respond in a validating way. When they say, you're a jerk, you're a selfish jerk, they're not going to say, oh, sweetie, I love you too. They're going to say, how dare you? What do you mean I'm a jerk? You're late more often than I am. And now the whole thing's toast. Okay. So notice this kid's not attacking. She's withdrawing. Mom doesn't know what to do. The kid's not expressing anything, which is also inaccurate, not explaining why she's sad, not explaining what happened. Mom is scared. She's overwhelmed, and she's starting to like, what's going on with you? Which does not help the poor kid organize her thoughts. She feels worse. She expresses herself less accurately. She withdraws more. Mom gets more frustrated. Oh my goodness, this is a mess. Or the child rolls their eyes, won't even look at the parents. I mean, can you see judgment on these parents' faces? Did anybody see judgment there besides me? You bet. She's got not only the rolling eyes on the front, she's got eyes on the back of her head. She sees the judgment too. All right. And of course, then we invalidate parents, partners, other people. We invalidate because we don't understand. It's inaccurate. The person doesn't say, this happened. This was my primary emotion. That's accurate. They don't say that. They say, you're a jerk, or that other person's a jerk, or I'm fine, when in fact they're suicidal. That's not accurate. And then, of course, they get invalidated because it's hard to understand. But of course, the person who's doing the invalidating has their own vulnerabilities, their own judgments, their own negative emotion that make it easier for them to be invalidating. And sometimes, honestly, we invalidate things that are perfectly accurately expressed. And that's the start of the cycle down here. Sometimes the cycle is accurate expression, get invalidated, then get dysregulated, then get inaccurate. And then the cycle just goes round and round and round. I'm not going to spend a lot of time on this, but this is a study we did a while ago. And the essence of it is that we stressed people out. It was nothing. They all knew they were coming into a study to get stressed out. It was perfectly ethical. And then what they didn't know is that the experimenter asked them, how are you doing? And when they talked about their emotion, which was usually I'm frustrated, something like that, the experimenter was, by the flip of a coin, was either validating or invalidating. So either said things like, oh yeah, of course it's stressful. Of course it's frustrating. The whole point, remember, the whole point of this experiment was to be frustrating. And when they do that, and then they continue to have the stressor, notice they feel way better. Okay, 2/3, 3/4 of the way better. But or the experimenter says, what's the big deal? Other people don't get stressed out. Not true, right? Other people do get stressed out. They can't acclimate, even though almost all of these people understood, they figured out that the experimenter was probably doing this on purpose. They still couldn't calm down. They couldn't do it because they were being invalidated. This green line is very powerful. It says that one of the most powerful things that we can do to another human being is listen long enough to understand their experience and figure out how it makes sense, how it's legitimate, and tell them it makes sense. That connection is soothing. We're hardwired for it from an evolutionary point of view. We're social animals. This study, okay, don't look at the date because then you'll have an inkling how old I am. Okay, but okay, this study was a long time ago. Look at this. These are the difference between very depressed people who were suicidal or not, but very depressed enough to be in hospital. And look what the difference is. The difference is the ones who were suicidal, their family member blamed them. The ones who were not suicidal, the family member acknowledged that they had family distress and they said, we want to help. I know that we're contributing in some way. How can we make this better? So they made it a we instead of a waggy finger you. And look at the difference between the yellow and the green. Invalidating versus validating responses. And in this one, we simply looked at families in the clinic whose kids were chronically dysregulated, a variety of things. And when we got a matched control sample from the community, we brought them in, we took video recordings. They all knew they were being recorded, just asked them to have conversations about how things were going in their families, and then had people who didn't know anything about them rate validating versus invalidating. And look at this, the parents of the clinic kids were way less validating and way more invalidating than the non-clinic parents and kids. Again, not blaming parents here. Please don't misunderstand, because the kids were also not expressing as accurately, right? They're both true. So this idea, right, that invalidation, number 5, creates much more distress and dysregulation. You don't believe me, right? Okay, please don't do this. Just do it in your mind, okay? Somebody you love, go, when they're having a lousy day, say, hey, what's going on? And they explain, say, well, that doesn't make any sense. You're wrong. You shouldn't be upset by that. That's just not a big deal. And see what happens, okay? No, don't do this. It's mean. It's awful. Don't do it, right? Because being invalidated is really, really painful, as the last slide, 3 slides ago, showed. Being invalidated is really painful. Being validated is very soothing. Okay. And then, of course, when it's chronic, when it happens not just from parents, not just from partners, but also from peers and bosses and coworkers or teachers, neighbors, it creates more sensitivity and reactivity. It actually contributes to more vulnerability, which then contributes to more distress. All right, that's a transactional model, right? Notice that the parts all affect each other. You have at least 2 people, one person in the top half, right? 1 through 4, the other person in the bottom half, 5 and 6, okay? But the bottom half could be many people. It doesn't have to just be one. The thing is that every box has important implications for treatment, because if we were to build treatment around this, you can see that treatment wouldn't just be treating the person's thoughts up here, this box. It wouldn't be just helping reduce stressful events in their life, because there are still going to be stressful events. It wouldn't be just helping people eat better and sleep better, but that can be important, but probably not by itself enough. It's got to do with this transaction. We're going to help the individual on the upside, and parents and partners and other people on the bottom side. So part of the solution, if part of the problem is inaccurate expression and invalidating responses, part of the solution is accurate expression and validating responses, or validating responses and accurate expression. It doesn't matter which starts this cycle, because it's a cycle. We can intervene with parents or partners and help them understand something about their children or their partners. That's going to make a massive difference for the other person, who's then, over time, going to understand better and express themselves more accurately, which makes it easier to validate. Or it'll start with the person expressing more accurately, and the other person will understand better, manage their emotions better, and be more validating. All right, the fourth little study I want to talk about here is this idea of remember I said, what's the process? Okay, that family functioning actually has a lot to do with individual outcomes, even when there's no family therapy. Okay, in this study, we compared DBT to psychodynamic therapy, This study is long ago published, but I'm going to talk about another element of this study. The main outcomes were published a long time ago. 63 young youth, basically young adults. They had up to 12 months of treatment. They were randomly assigned to DBT or psychodynamic treatment. And look what happens in the DBT condition, 12 months of treatment. In the DBT condition, like you'll see in several graphs, DBT outperformed the psychodynamic treatment. It had better outcomes in general. By the 12-month period, better outcomes, and continued to have better outcomes in the follow-up period. Okay, that's interesting. Hold on to that one. What happened, DBT outcomes were also better in terms of depression, in terms of suicidality, and in terms of social adjustment. But that's for later. Okay, so hierarchical linear modeling, don't worry about this. But the question here was, is family functioning a pathway that leads to good outcomes? Remember, none of these treatments included family work. None of these treatments brought parents in, okay? So what we did was we found that the DBT group was associated with a bigger decrease in family distress. In other words, better outcomes with families. Okay, in terms of that, and family distress scores didn't significantly change in the psychodynamic treatment. Family functioning mediated suicidal outcomes and self-harm outcomes. What does that mean? That means regardless of treatment, if family functioning didn't improve over the course of the individual's therapy, they were less likely to get benefits from the therapy. If family functioning got better over the course of therapy, they were more likely to have good outcomes. DBT had better outcomes. DBT had better outcomes with family functioning. Regardless, even in the other condition, if they had better outcomes with family functioning, they had better outcomes individually. So the interaction term was significant. So even when controlling for emotion dysregulation, this was true, okay? This is actually, don't worry about the numbers here. This is very interesting because what it's saying is quality of relationships is actually a determining factor in individual treatment outcomes. I thought it was all in the brain. I thought it was all about, wacky amygdalas going berserk and dysregulating people. Well, no, not really. There's more going on here. So the key conclusion is that family functioning is relevant to people in treatment for suicidality and self-harm in people with BPD. Almost all of these people had borderline personality disorder, regardless of treatment, and even when no family interventions are present. This definitely supports the transactional model. Another study, we looked at people in their daily lives using something called ecological momentary assessment. Very fancy term. What that means is that on their phone, they got a beep a certain number of times a day. When they got a beep, they opened their phone and they answered a few questions about what's happened in the last 15 minutes and what's their emotion, and do they have urges to hurt themselves, basically. And what we found was invalidation by others led directly to self-invalidation and led to shame. And both of those, along with the invalidation itself, all three of these contributed to the presence of self-injurious thoughts and behaviors. Wow, invalidation by others, direct line and two indirect lines through shame and self-invalidation created urges to self-harm. Wow, that's pretty important. And then we looked at parents and said, well, that's interesting. Whoops, sorry. 432, mostly parents, some other family members, who had a loved one who'd made a suicide attempt, medically serious self-harm. Nearly all of them, 96+%, reported experiencing intense fear, helplessness, and horror. And half of them met criteria for PTSD and the other acute stress disorder. So having somebody you love make a suicide attempt is very destabilizing. This is no surprise to anybody if you think about it. Wow. So this transactional thing has got something going on. Parents and partners invalidate a lot more when we're dysregulated. And when, okay, poor Domingo made a suicide attempt, I've got fear conditioning, I'm more likely to be escalated, vulnerable, and to hit my dysregulation point more frequently, and therefore more likely to be invalidating of poor Domingo. And that could show up in a lot of different ways. And that contributes, of course, to further dysregulation in kids and partners, if we're talking about partner to partner as opposed to parent to child, which of course contributes to further confusion on the part of the first person and gets them to create more validating responses. So this is just a loop after loop after loop. All right, last study I want to tell you about is a randomized trial. Well, what happens when you've got very dysregulated and suicidal kids in DBT, in this case, and you randomly give their parents skills or don't, okay? So those who got the parent skills, that's the green. I'm going to show you, I think, 3 graphs, maybe 4, I forget. And in each graph, you're going to see the parents who got the kids whose parents got the parent skills, right? The kids reported more improvements in validation from before the parents got skill training to after than the parents who didn't get the skill training. The kids reported fewer invalidating responses from their parents if their parents got parent skills. And they reported more improvement in emotional availability. Wow, that's a trifecta. That's very useful. And problems with emotion dysregulation went down significantly more if their parents got parent skills. Okay, listen to this. The kids had fewer problems with dysregulated emotion if their parents got parent skills. Wow, that's kind of interesting. Parents are not neurosurgeons. They're not operating on their brains, right? They're transacting with their kids. They're having conversations. Their skills are leading them to do more listening and less reacting, more self-care, more self-soothing, more self-regulation, more understanding, more curiosity, more understanding. And improvements when parents are more validating and less invalidating, it led to better outcomes for the kids in terms of emotion regulation and depression. By the way, for those of you who are statistically savvy, these R-squared things. The 36 here, the 0.36 and the 0.34, that means that it's accounting for 36% of the outcome. That's a whopper. That's a huge amount of outcome just from parent skills improvement on more validating and less invalidating. All right, so what can we conclude? We can conclude that, number one, emotion dysregulation is transdiagnostic. And number two, the transactional model has a lot of support to explain the development of problems with emotion dysregulation, how it can become chronic and severe, how intervening on both sides, the person who's labeled the client or the patient, but also the parents or the partners that interact or transact with them on a regular basis. And it has great predictive power over linear models like interactional ones in terms of all kinds of outcomes. So using the transactional model as a map or a guide for interventions could turn out to be extremely efficient, as well as effective. And by the way, cost effective, because then there are programs that can offer pretty inexpensive, low-cost interventions like Family Connections, which is free, that are super helpful, even if the child or the partner doesn't have good services available to them. All right, I want to stop there, and thank you for your attention, and I'm hoping you have some questions.
Yes, Alan, there's a question here in the chat. Hello, I have BPD. Do my family has to know my diagnosis? I've seen professionals saying yes, others no, but I'm also afraid they look at me as a monster. Thanks.
Oh my goodness. Well, first, let me be clear. You're not a monster, okay? Welcome to the human species. You're part of the human species, okay? Whoever you are here. So take a deep breath and just notice that you've got, like 75 other human species people here with you. You're not alone, okay? Now, if you have BPD, that's a label. It's a category. Who cares about the label? The label matters in mental health when it gets you appropriate treatment. That's when a label matters. In medical care, the correct diagnosis usually tells you something about the development of the disease. In mental health and psychiatric diagnoses, the vast 90-something% of our diagnoses do not tell us anything about any disease process. There's no evidence that there's a disease process, except for a handful of pretty serious disorders, like Alzheimer's disease. That's a disease. It's a biological entity. There are things we can do behaviorally to help, but that's a disease. That's not a disorder of emotion dysregulation. So I would encourage you to talk to your family about how you're struggling, how it feels awful, and be descriptive about how things feel for you. If you think that the label, that the term borderline personality disorder would be helpful to them, it's probably okay. If you think that they're going to be judgmental or overly scared by that, I don't think the label is the thing that they need to understand. They need to understand your experience, and you can tell them that just by describing what it's like to be you in small bits over time. Not all at once. That's probably too much, right? Is that helpful? I hope that's helpful.
Makes sense. I have another question here that related to when you were explaining this transactional model, and you gave the examples of the validating response and the invalidating response.
Mm-hmm.
And I have a question related to whether in both examples, does the person goes through the same emotions? Let's say if he gets angry because the son wasn't like paying attention, he'll also get angry when validating, but goes through it in a different way. That's the question.
So would the son be likely to get angry when validated?
No, the parent.
The parent.
When he gave the validating response and the invalidating response, does the emotional sort of equation, is it the same? They're asking.
Well, I think it's different, but I think the idea here is to say, okay, what can I do? What am I missing in terms of my emotion? One of the nice things about talking about transactions with people that when our negative emotions are low, people that we love, we care about, we want to have a good relationship, is that emotion is always available to us. And to be active about finding those emotions instead of passive about them, right? I think we often talk about like, I love you as though it's a shirt that I'm wearing, okay? It's something I have. But actually, love is something we do. Angry is something we do. It's an emotion. It's a behavior, right? And the fact is that if I'm angry at Domingo, that's because what I'm paying attention to is something, A, that I don't like, and B, I'm allowing myself to react to it instead at a dysregulated level, instead of saying, okay, this is somebody I love. I don't understand why he's not doing what I want him to do or why he did this dangerous thing. I don't understand it. So I can bring love and curiosity to the moment and still be scared, right? And disappointed. But notice the anger gets much smaller because all those other emotions take up more of our space. They're totally legitimate. If you're also angry, it's not going to do damage in the same way. If I say, sweetie, I'm really worried about you. And I don't like that you went exactly against what I asked you to do. So we got to figure this out. If that's angry, that's fine. That's just accurate expression with love and curiosity and a willingness to collaborate. That's okay.
Because it's regulated. Yeah.
It's regulated because I'm aware of my short-term and my long-term goals. And I'm paying attention to someone I love, remembering this is someone I love. And then we have love because it's available. It's always available. If we can love somebody when our negative emotion is down, we can learn to love them when our negative emotion is higher, which helps us. That's soothing for us. It doesn't mean we have to give up our other goals. It just means we're more balanced about it and much more effective in the way we do it.
We have other questions in the chat here. I'm going to read some of them. This is a psychotherapy question. Is it effective to use the transactional model with parents, in session with parents, if they can't make it to family connections? And that way we can teach them the dialectical dilemmas and everything.
Yeah, great question. My short answer, yes, absolutely. We have copies, the last slide, just the end slide, not the step by step, but the big picture. We have copies of that. We use that routinely with parents, with partners, with families. They love it because it's not blaming anybody. It's, oh, I'm starting to understand why my child, why my partner reacts that way. It doesn't mean I like it, doesn't mean it's okay, but I get it. And now I can understand it. It's different. I also understand now why I'm reacting the way I'm reacting. And now, as I said, each box has the opportunity to do something different. It's like, wow, we have a map for how to do this differently. That's great. It's very empowering that way.
Should we include parents in session with the adolescents in order to work with them and teach them how to validate each other?
Well, that is a very big question that a legitimate answer would take, sort of 4 days of training. But the short answer is yes, when it's productive to do that, right? When both parties are regulated enough to practice accurate expression and validation. But until person A can express accurate, it doesn't make sense for them to come in and be inaccurate and critical and judgmental. It doesn't make sense for them to be accurate and have the other people invalidate them.
Yeah.
So yes, bring them together when they're regulated enough that you can coach them to be successful. There, 4 days of training in a minute and a half. That's pretty good.
Yeah. What are some considerations when determining the most appropriate treatment for families, whether is it FC, individual family DBT, or multi-family skills groups?
That's a really good question. I think there are two ways to answer that. One is very sincerely, it depends on what's available. They are all legitimate, helpful. There's evidence behind all of those. They're all legitimate. Family Connections, let's just be honest, is free. And so there are no cost barriers for families to do Family Connections. And that's super helpful for many families. This is why Perry and I created Family Connections. And so and could you do DBT family therapy or have a parent group or a couples group? Absolutely, if you like to do it that way. I would say it depends on the resources you have to provide, the resources the family has to pay for whatever services there are. I think they're all legitimate options. If there's a lot of severity, if the problems are very severe, you may have to start with one option and then build. You may ultimately know the most intensive option is the DBT family therapy one, because it's one family at a time. It's more resource. For very serious problems, that might be some place to go eventually, but that doesn't mean they can't start with something like a Family Connections group or a parent group or something like that that's more cost effective.
Okay, another one. With patients, is explaining how the model may relate to their interactions or symptoms help them regulate in the future? The question is more so in relation to your experience with this population.
Yeah, good question. I don't think that understanding the model helps them to regulate. I think it helps them be motivated to work on the skills they need to motivate. They understand why they're working on that skill, why that skill can make a big difference in their life. It's not just a book says it's a good skill, It's like, if you want to build a bridge, that's a good reason to learn. I'm not an engineer, but it's a good reason to learn algebra. I think you need to understand something about math if you want to be an engineer. It's a good reason, as opposed to, everybody should know, how to calculate the area under a parabola, which I don't remember how to do, by the way. But, I haven't done that since I was in high school when I was part of a math class, right? I mean, I probably could do it once. So, right, who cares? But if I wanted to build a bridge, I might, oh, that's important. I got to go look that up. I got to relearn that.
Okay, there's another one here. If one thinks that that you have emotional regulation disorder, how do you bring it up to your therapist? Question.
Oh boy, that's a hard question. I think it depends on, if you've got problems with emotion regulation, your therapist doesn't know that. I'd be kind of wondering, well, what is your therapist thinking you're struggling with, and what's getting in the way of you not having talked about that already. I would be just very blunt and descriptive and say, hey, I think we're missing something here. My emotions are all over the map, and I get my emotions get out of control, and I want to bring that into our conversation. Yeah, like do that tomorrow. Yeah, it's a good idea right away.
Yeah. I don't see other questions in the chat. Anybody else have a question? ¿Alguien más tiene alguna pregunta que quiera hacer? Si la quieren hacer en español también, yo puedo ayudar a traducir. Melissa.
I'm just wondering because I'm very interested in BPD and self-stigma and just like wider, like how it's such a stigmatized condition. And I'm just like seeing a lot of parallels between the transactional model and just like how BPD comes to be stigmatized and how like self-stigma develops. So I'm just like wondering if this model has been adapted to like include like other social structures that are not like that don't include only like the family system or like the more immediate.
Oh, you bet. You bet.
Yeah.
We have a nice little webinar on our website about racism as an invalidating environment, for example. It's a different kind of invalidating environment. It's much more pervasive. It's at a different level. We have a whole model that's outside the family and immediate kind of one-to-one validation, but the social structures that are invalidating. So the short answer is absolutely. And I think it's very important to consider that.
Thanks.
I mean, this is true for anybody who would identify themselves as different in some context, right? That difference might be applauded. Like if a person's a particularly good athlete, okay, we say yay, okay. But most things that are different, we say boo, most, and whether that's race or, again, there's no invalidation for race if you're among people who are like you, right? But if you're not, if you're different, there's the misunderstanding and the subsequent invalidation, both direct and indirect. This is true, of course, for people with any difference or gender identity, sexual preferences, and all of these things. Right? Exactly. Yeah. Great question.
Here's a nice comment. I feel as a student and as a patient that your way to explain emotions and talk about the diagnosis was very respectful, and I felt very validated. Yeah,
That's great. We're just people together,
Question here. Hi, I'm wondering where I can find more information related to the seminars and research that you talk about. Please let me know. Thank you. We can help with that, I think. Another one. Is there information about microaggression as invalidation? Interesting.
This is a tricky and sometimes touchy question. So let me just be descriptive about it. Okay, so I think we have to define microaggression more carefully. And I think that what I mean is I want to bring it into a transaction, because I think right now, when we talk about microaggression, sometimes there's a waggy finger at the person who we say is committing the microaggression. I'm not saying they're not. I'm simply saying we get judgmental of them for doing it, when in fact, we may not understand that behavior, and they may not understand its impact. And so rather than labeling it in a judgmental way, let's say, hey, when you do this, I'm wondering what you mean by that. Or, hey, when you do that, it reminds me of this. And that doesn't feel good to me. And to be descriptive and not blaming about it. There are lots of examples of this. So I think that the idea of, in some ways, calling it a microaggression is an interesting term that's, I think, got some benefits to it because it's not making it so huge. On the other hand, it's presumptive that the person's behavior is aggressive, when in fact, it's might be much more nuanced than that. Doesn't mean it doesn't hurt your feelings. It just means that it might hurt your feelings for a variety of different reasons. And a conversation about that might make a big difference.
Chat again.
I have a question, Dr. Rossetti. In family connections, when we talk about transactional model, the family members, at least from the one that I seen, they tend to bring up how their own experiences with family members have been worse, that what they're providing to their family members is better in comparison.
Sure.
How do we tend to deal with that in terms of like the guiltiness, those cultural phenomena where like, oh, in my time, times were worse. You should be grateful.
Yeah.
At
Well,
least I don't hit you. My father hit me, something like that. Okay.
Yeah.
yeah. Oh, I both love your question and oh, your question, right? It's a good question. I think the answer has a few parts. One is to ask first, to start by asking more questions. Like I might say to you, Kevin, so okay, so you say that your family, could you give me an example of something your family did? Because it sounds like it was probably pretty awful. And I mean that very sincerely, you know. And then you don't have to do this, but you give me an example and I validate because oh my gosh, that probably, and then how was that for you? And you say it was awful, it was awful. I say, okay, so on the one hand, you know how painful it is to be treated that way. On the other hand, you didn't have models, anybody teaching you how to do it in a different way. So the fact that you do less of that, wow, that's fantastic. And what would you think about working on doing even less than you're doing now? Like actually more skills, because that's good for you too. You know that it's painful. If I drop a 20-kilo anvil on your toe, it hurts. If I drop a 10-kilo anvil on your toe, it hurts less. You know, I might break fewer bones, but it hurts. But what if I don't drop the anvil on your toe? What if I drop the anvil over there instead? You know, and I'm not, there's no should. I'm just saying, like, what do you think? Wouldn't you like to be the most skillful you can? Anyway, so and I went way too fast for that. I mean, I would take more time, but really validate their experience and invite them to think about what kind of relationship they want, what impact do they want to have on their loved one. In my experience, parents, partners, siblings, grandparents have love in their heart, you know, and they're just, when they say, hey, it was so much worse for me, what they're saying is, I feel helpless to do better. I've been struggling. I've done better. Why don't you appreciate it? The first answer has to be, oh my goodness, let's stop and appreciate it. Good point. That's the first. And then, and how about we keep working at it? You know, it's a both, you know.
Thank you.
Kevin, is that helpful at all?
Yes, it has been.
Great. And great that you're doing Family Connections. Warms my heart. That's just terrific.
I love it.
Wonderful.
Yeah, Kevin is one of the ones that have been true to Family Connections. We have a few groups. It's doing great. ¿Alguien más tiene alguna otra pregunta, comentario? Any other questions? No?
I have one, but it's loosely related. It's based on one of the studies that you did with Allison. I met her like before I started.
Yeah.
So I was just like wondering like conceptually how you differentiate like self-invalidation versus shame, because I know like shame may be like the emotional response to the self-invalidation, and I cited that study for my dissertation like based on like self-invalidation and stuff, but I was just like wondering like how you conceptually and operationally sort of differentiate those two, because like they sort of
Yeah.
mesh.
Yeah, it's a great question. I think that the short answer is just by measuring them in different ways, asking different questions. And so we actually have a self-validation, self-invalidation questionnaire. And in that study, we didn't use the whole thing because they were doing it several times a day. We used just a couple of questions plucked from the questionnaire, but they seem to be working pretty well. And shame is really a description of an emotional experience as opposed to the verbalization, like I'm an idiot, you know, my appraisals of myself are negative. So it's really this brain, this cognitive emotional separation, which you know, let's face it, is a little bit arbitrary, right? Because they're constantly in transaction too. But I think that by doing the ecological momentary assessment, the idea was that we could look at the sequencing, just like you would in a mediational analysis. The sequence, you know, you look at like and if you do A first temporally, A shows up first, and you look at its impact on B. If A happened first, B couldn't have caused A, right? And if you do it the other way around, you say, when you see B first, how much of A do you see? And if you see A after B, then, okay, maybe B caused, right? So you keep bootstrapping it in different ways. You have multiple time points, and then you look at it in different sequences to see which one seems to be the most predictive. Allison's way better at the math than that. I'm just telling you what she did. I didn't do it. She's a whiz. Yeah. Yeah, she's really good.
Thank you. ¿Alguna otra pregunta? Any other questions, comments? No? Perfect. So, Alan, we want to thank you. Alan está en Irlanda, así que son 6 horas más. What is it over there, like 10 o'clock already?
9:20, not so bad.
Yeah, 9:20. Okay.
Almost dark. Almost dark.
Almost. Yeah, over there it's like at 10
Pretty
p.m.
far north. Yeah.
Yeah.
All right. Well, thanks so much for inviting me. This was fun to do. I hope you got something out of this. And again, just a pleasure to be here with you. Thanks. Take care.
Always. Thank you for your time. Gracias a todos. Bye,
Hasta luego.
everybody. Mañana es el simposio. Se pueden conectar también y asistir en Ponce. Bye, Alan. La grabación se va a grabar y se va a subir al canal de YouTube, ¿ok? Bueno, gracias. Nos vemos mañana los que estén allá.